welcome the participants of the second World Congress on Heart and Cardiovascular Diseases. This important event brings together colleagues from most countries of the world. Of course, reports and discussions help us develop clinical science, which will be reflected in supporting our patients. My report is devoted to the analysis of the prevalence and the characteristics of the two important risk factors among adult population. The report is independent. There is no conflict of interest. According to WHO experts, mortality due to ischemic heart disease, cerebral stroke, and cancer is growing rapidly throughout the world. It should be noted that the using of new diagnostic and treatment methods has somewhat slowed down the pace of the process. But the problem remains relevant, especially in developing countries. In the 6th of the last century, the main risk factors for cardiovascular diseases were considered as smoking, hypertension, and hypercholesterolemia. After 40 years, come to the 4 metabolic disorders such as obesity, metabolic syndrome, and type 2 diabetes. Of course, together, they increase the risk of cardiovascular complications. The series of multicentral European studies such as EuroAspire have demonstrated that control of hypertension and hypercholesterolemia has been improved in patients with myocardial infarction over the past 20 years, while the contribution of diabetes and other metabolic disorders is increased. In a classical international interheart study under Professor Salim Youssef from Canada, abdominal obesity and arterial hypertension were among the 5 significant risk factors in association with acute myocardial infarction. In general, obesity is considered a global health and social problem throughout the world. Today, more than 2 billion people suffer from overweight, and about 700 million people are diagnosed with varying degrees of obesity. And over the past 50 years, the number of obese people has doubled. Among the countries where the number of obese patients is rapidly growing, the top 5 are rich Arabian countries, the United States, Lebanon, and Turkey. This list also includes countries in South America and Asia. However, I would like to remind you that obesity plays a role in the development not only diabetes and cardiovascular disease, but also respiratory disease, hormonal disease disorders, arthritis, cold, and some type of cancers. We can talk about the systematic effects of obesity. The second problems that I would like to draw attention is hypertension. Over 30 years, the number of people diagnosed with hypertension has doubled among both men and women. Unfortunately, effective control reach up to only 23% of cases. In rich and middle income countries, the situation in controlling hypertension has improved markedly. However, the problems persist in low-income countries. This slide shows countries with high prevalence of hypertension among men. This is first in Central European countries, Russia, African, and South American countries. The same, but some slight less pronounced patterns in observed among women around the world. Dear colleagues, the number of deaths is closely related to the increase in blood pressure numbers. It can be seen that the increase in systolic blood pressure from 115 mm H leads a 5-fold increase of the cardiovascular disease, coronary arterial disease, 1.5-fold increase the ischemic stroke, 2-fold increase the hemorrhagic stroke, and 1.5-fold increase in other complications, include chronic kidney disease. If we know about global trends in the prevalence of these disorders, then the question arises, why conduct population-based studies? First, the implementations of population studies help determine not only the frequency of certain disorders, but also the identification, gender, and age aspects of risk factors. Second, periodic monitoring of this disease contribute to the development, the prevention program at population level. And third, according to the prospective study, the risk of cardiovascular disease can be reduced in up to 50% case by correcting risk factors. For this purpose, we planned a cross-sectional study to identify a number of risk factors among men and women in the separate region of Russia, Vladimir region. This historical central region characterized by high adult mortality from cardiovascular diseases. The population in the region the last year is 350,000 people. Population characteristics. A cross-sectional population study was conducted from May to 2018 to 2020 in 5 cities from Vladimir region. The study included 1,350 people, men and women, aged 30-69 years. The response to the study was less 80%, a very high response. In total, 1,174 people complete the study. Of this, about 36% men and about 64% women. This slide shows the average age of men and women, the number of participants from different 5 cities. More participants were represented from the capital of the regions, Vladimir city, and second industry city, Murom. The average age in the 3 cities differently significant between men and women. No gender difference were identified in the 2 cities. The average age of the participants was about 54 and 56 years. Methods. Respondents were asked a questionnaire, include question of social status, family history, smoking status, alcohol, as well as risk factors, biological and behavioral risk factors. Everyone had their blood pressure measurement, heart rate, both body weight, height, waist circumference. Body mass index was calculated. Also, to assess of left ventricular hypertrophy, all respondents underwent a resting ECG. Left ventricular hypertrophy was assessed using 2 criteria, Sokolov line and corneal voltage index. For statistical analysis, we used Welch's t-test and Fisher t-test. In 2 large cities, Vladimir and Murom, systolic and diastolic blood pressure in men turned out to be significantly higher compared to women. In other cities, the average blood pressure values do not have gender difference. Heart rate were also comparable between men and women. Overall, the prevalence of hypertension among men was 41.5% and among women 39.9%. In 4 cities, the frequency of hypertension between men and women was comparable. Only in the Vladimir city, the prevalence of hypertension in men was 25% higher than in women. An important part of the study was the assessment of target organ damage in hypertension. Left ventricular hypertrophy was detected in 30% of cases among men, and the same trend was observed among women. There was no statistical difference in the incidence of left ventricular hypertrophy between men and women in 4 cities. In 2 large cities of the Vladimir region, the waist circumference of men participants turned out to be significantly large compared to women. And the body mass index had gender difference only in 1 city, this is Vyazniki. In other cities, body mass index and waist circumference were comparable between men and women. So every third man in surveyed population was obese, different diseases obesity. Among women, this figure was 42%. The difference between then turned out to be statistically significant. Interesting that in some cities, the difference in the prevalence of obesity reached from 1.5 to 2 times among both men and women. For abdominal obesity, different pictures is observed. In the population, the prevalence of abdominal obesity is 2 times higher than obesity according to body mass index. Among men, every second person has abdominal obesity. Among women, more than 70%. The differences are significant. In 4 cities, the prevalence of abdominal obesity among women was significantly higher than among men. I would like to present this discussion. The incidence of arterial hypertension among men and women was comparable. At the same time, ACG sinks or parameters of left ventricular hypertrophy are detected in every third adult examined. The prevalence of obesity in the Vladimir region has a gender difference due to its greater severity among women. In organized population, every second man and 2/3 of women have abdominal obesity. The 2 factors are associated with high rates of other main risk factors, which is reflected in the identification of high and very high cardiovascular risk in the surveyed population of men and women in the Vladimir region. In this population, every 5th man has a high cardiovascular risk according to the European score scale, while among women, this figure is half as much. The differences are significant. Also, we can see the same tendency in frequency of very high risk. The prevalence of very high cardiovascular risk among men also high. At the same time, the difference between men and women is the frequency of very high cardiovascular risk was 2-3 times. In this case, the role of the other important risk factors was abuse. And for take-home message, in the surveyed population of men and women in the Vladimir region, the prevalence of obesity and hypertension was comparable about 40%. Hypertension is also more likely to be associated with left ventricular hypertrophy. The incidence of obesity and abdominal obesity has gender difference due to its greater severity among women. Obviously, the correct obesity and hypertension lifestyle change at the population level must be combined with the use of antihypertensive therapy to achieve target blood pressure levels and regression of left ventricular hypertension. And I would like to thank our research team. First, the Professor Oksana Drapkina, project chairman from Moscow, Professor Lyudmila Sushkova from Vladimir, Dr. Roman Isakov from Vladimir, Dr. Vladimir Kutsenko, our statistic staff from Moscow. Also, I would like to thank Heart of the Health Department of Vladimir region, head of the Vladimir State University. Special thanks to doctors and nursing staff participating in the study. And the last, finally, my slide. The thank you for your attention is a beautiful view to city center, historical city center of Moscow. Is the Red Square. Thank you again for your attention.
I'm Professor Dr. Lulzim Vokri, vascular surgeon from Kosovo. My clinical research interest is in the field of atherosclerosis, grinding and melting of atherosclerotic plaque in blood vessels, and creation of sutureless vascular anastomosis with biodegradable material. My presentation plan includes general introduction, in vitro and in vivo study experiments, discussion, general conclusion, and perspective of this study. General introduction, historical data. Since the pioneering work of Karel, many other alternatives have been developed for the realization of sutureless vascular anastomosis. Our objectives in vitro and in vivo evaluation, the feasibility, efficiency, the strength of the anastomosis using the new vascular connector. Evaluation of the time of creation of anastomosis, blood loss, resistance to maximum pressure, and finally test of resistance to the pressure and tensile strength and short-term permeability. Given the results in animals, the ultimate goal of this sutureless vascular anastomosis technique is its application in clinical practice. Materials and methods. The first study, various tests on a bench test, ex vivo sheaths, carotid arteries, and cadaveric femoral arteries were performed in vitro with the new vascular connector or with sutures as a control group. The second study, total of 19 sutureless vascular anastomosis of carotid arteries and 5 sutured anastomoses were made in 12 sheaths. The time of the anastomosis, the blood loss, the safety, the permeability, and the tissue reaction were studied. Design, manufacture, evaluation of a new vascular connector. We have created and developed a new vascular connector. The objectives of this experimental study were to conceive, to manufacture, to test the difficulty setting up our new vascular connector, of its effectiveness, of its suitability, and of its safety. We went through several stages of defining the design. History, conceptual, morphological, and mathematical evaluation of the new vascular connector. We can see here the first version of new vascular connector made from a mesenteric made with man. The second version of new vascular connector in PVC plastics. And finally, the third version was developed mathematically in 3D as a STL5. It consists of 3 parts. The material chosen was photopolymeric resin LS 6000 photopolymer. This version of new vascular connector thanks to software in STL5, which allows us to go from the conception of an object to its realization thanks to a 3D printer. We have designed and manufactured all dimensions of new vascular connector corresponding to diameters of 4 to 10 millimeters in 0.1 increments. Sorry for this technical. New vascular connector of third generation consists of a conical inner tube and 2 tapered outer rings. The diagram in UT. This is a size of blood vessel mathematically concept. This is a active force between the inner tube and the blood vessel water, inner tube, into the vessel blood. This is a male outer rings, female ring, and this is a male ring. The aim was to test the the type of sutureless vascular anastomosis in vitro using the new vascular connector on a test bench with vascular prosthesis, freshly harvested carotid arteries from sheep, and femoral arteries of cadaver. 34 end-to-end vascular anastomoses were created, 17 sutureless and 17 conventional. We use vascular prosthesis in PTF graft and Dacron graft. Also freshly harvested carotid arteries from sheep, 6 new vascular anastomoses and 6 conventional anastomoses. And in cadaver, we are using 5 anastomoses creation with new vascular connector and 5 conventional anastomoses. This is a schematic presentation of sutureless vascular anastomosis with NCV, 3D cuts, 280 degree. This is step-based procedure of sutureless vascular anastomosis. So, a series of tests were carried out on a bench test to measure the time to perform anastomosis, maximum pressure resistance at the anastomotic site, and tensile strength of anastomosis. Results. Anastomosis with new vascular connector versus conventional anastomosis, it was significantly faster. The resistance to peak pressure of the anastomosis immediately after the procedure was higher in the anastomotic with new vascular connector versus conventional anastomosis. Here we have a move file, 32 seconds. We can see that. So mean anastomosis, mean patient anastomosis time, it was been for 24 seconds. Here we have testing resistance, no leakage in anastomotic site, more than 300 millimeters of mercury pressure, no leakage in anastomotic site. In other hands, conventional anastomosis was more resistant to tension in Newton versus anastomosis with new vascular connector. We can see the value here. No failure and kinking of the vascular graft used was noted on gross examination. Preliminary results from in vitro experiments helped to determine the optimal configuration of new vascular connector for further in vivo studies. Conclusion. Our technique without suture with the new vascular connector is original. The shape and dimension were calculated with a mathematical model on electronic file, which was used to order a 3D print to produce it in various sizes. NVC enables simple, rapid, and safe anastomosis in all vascular grafts used. The safety and robustness of this new vascular connector has been demonstrated in bench test studies with prosthesis, freshly harvested sheep carotids, and cadaver femoral arteries. The results obtained after offer possibilities for the practical animal application on this technique. So we continue with in vivo study in sheep of sutureless vascular anastomosis. We redesigned the previous version of the new vascular connector. We have developed a new experimental model of sutureless vascular anastomosis in sheep using new vascular connector. The anastomosis system was evaluated on feasibility, time required to perform the anastomosis, blood loss, resistance to mechanical stress, and short-term permeability. Here we can see axonometric exterior view of the new vascular connector. Here in 12 ships, 24 terminal carotid anastomoses were made, 19 of them with new vascular connector and 5 conventional anastomoses. The outer rings of new vascular connector have been inserted at the proximal and distal part of the artery, and then introducing the inner tube at both ends of the artery. The 2 outer rings are then closed axially to finalize anastomosis. Here also we have a smooth file from 18 seconds, creation of sutureless vascular anastomosis in carotid ship artery. This is University Veterinary in Sassari in Italy. Materials and methods, the measurements carried out during the experiment. Time necessary for the realization of the anastomosis, blood loss at the anastomosis site, intraoperatively measurement of maximum pressure at the anastomosis site, postoperative measurement of maximum pressure and tensile strength at the anastomosis site, the permeability of anastomosis by Doppler. Results. The surgery was successfully performed in 12 ships. The anastomosis time was shorter with new vascular connector versus conventional anastomosis. Blood loss in anastomotic site with new vascular connector not significant. Conventional anastomosis 3.06 milliliters. Intraoperatively, the blood pressure at which leakage occurred was higher with new vascular connector. Postoperative leakage test after surgery was higher with new vascular connector versus conventional anastomosis. Postoperatively, conventional anastomosis demonstrated greater tensile strength than new vascular connector. All sutureless vascular anastomosis and conventional anastomosis were patent immediately after surgery. 10 ships survived 4 weeks after surgery and 2 ships died. Doppler ultrasound in the first postoperative week. 16 anastomoses with new vascular anastomosis in 10 ships. 5 of them had thrombosed, 11 were patent with a permeability of 69%. Doppler ultrasound at 4 postoperative week. 16 anastomoses with NVC. 8 were thrombosed, 8 were permeable with a permeability of 5%. All conventional anastomoses were patent, but 1 stenosis was noted. Conclusion. This is our first experience with new vascular connector as a model of sutureless vascular anastomosis in live sheep. Anastomosis with new vascular connector takes less time, reduces blood loss, facilitates assembly, and strengthens anatomical strength at the site of the anastomosis. New vascular connector is a simple and feasible device for the creation of sutureless vascular anastomosis in sheep. However, more animals and the longer follow-up are necessary in view of the frequent thrombosis before concluding that it is superior to the conventional method. General discussion. Our results of creating of sutureless vascular anastomosis showed that the anastomosis with NVC is feasible without immediate complication in vitro and in vivo in all animals. Sutureless anastomosis performed better compared to conventional anastomosis in the time of anastomosis. Sorry. Blood loss at the anastomotic site, sailing, and resistance to internal pressure force. Advantages of sutureless vascular anastomosis versus conventional anastomosis. The SVA systems do not penetrate the vessel wall, and this decreases the risk of bleeding, stenosis or pseudoaneurysm in anastomotic site. The overlap is only 2 centimeters, ensuring fixation and good strength of the anastomosis. Intraoperatively, no anastomotic leakage up to 280 millimeters of mercury, no dissection of the anastomosis, no NVC displacement, no major abnormalities at the site of the anastomosis. The blood pressure at which leakage occurred was higher both intraoperatively and postoperatively compared with conventional anastomosis in vitro and in vivo study. General discussion. Conventional anastomoses were more resistant to traction compared to sutureless vascular anastomoses. Intraoperative angiography and Doppler ultrasound and postoperative control Doppler in first 7 and 30 days showed patency of anastomosis in half of the cases. Microscopically, 4 weeks after surgery, the lumen was endothelialized in the permeable vascular anastomosis made with the NVC. Anastomosis with NVC showed a higher rate of thrombosis. The defect in the formatting of new vascular connector as a whole may be largely responsible for this thrombosis. The lack of biocompatibility and the chemical composition of the new vascular connector material causes thrombogenicity. At 4 postoperatively week, 50% of the anastomoses with the new vascular connector were thrombosed, unlike the conventional anastomoses, although usually thrombosis occurs in the early postoperative period. In this context, the use of biocompatible and biodegradable material could improve its permeability. The evaluation and structure of the new vascular connector is contemplated. One goal, to replace the new vascular connector with other new vascular connectors made from organic or biodegradable material. Therefore, the NCV can be made from a relatively flexible metallic memory material or from a biocompatible and biodegradable material. The risk of intimal hyperplasia may be a limiting factor for this type of vascular reconstruction at this stage of the trial, given the presence of the new vascular connector tube inside the lumen. Biocompatibility should help achieve the best results in terms of anastomosis permeability. These models inevitably have a number of biases. Small number of animals, short observation period, and animal healthy vessels. These studies could in the future allow the development of a standardized, reliable, and rapid execution technique. Our work on sutureless vascular anastomosis has shown that this is an ancient research by vascular surgeons. No achievement so far has been satisfactory. Many medical devices have been offered without winning membership. Current attempts seem promising. Anastomosis using a manufactured connector. Anastomosis thanks to the connector of our standardized manufacturer. Anastomosis using hybrid techniques. In the perspective of this study, the future lies in hybrid techniques that would combine sutures and new vascular connector made of biocompatible and biodegradable material, a new medical device for measuring the internal diameter of vessels in cylindrical shape with diameters from 2 to 50 millimeters in 0.25 millimeters increments, a special mold to measure the outer diameter of the vessel, also in 0.25 millimeters increments. In the future, a biodegradable new vascular connector will be tested in animals over a longer period in order to assess the permeability of the anastomosis. The ultimate goal of this work is the transition from experimentation to clinical application and phased new vascular printing in the operating room with the sophisticated 3D printers. Thank you for your attention.
To present you my presentation regarding the non-occlusive mesenteric ischemia in cardiac arrest patients. Mesenteric ischemia seems to be a serious problem in cardiac arrest patients, and unfortunately there is not much known about this condition. As you know, the cardiac arrest mortality is about 10%, and in refractory cardiac cases, which could be treated by ECPR, the survival rate is about 27%. And the ischemia reperfusion injury of the brain remains as a critical factor affecting the final neurological outcome. And then specifically intestinal ischemia can have significant consequences regarding the prognosis of these patients. Let me start by giving some information and detail about the non-occlusive mesenteric ischemia. It is a severe and underestimated intestinal complication of all shock conditions, and including the cardiac arrests. And it is characterized by impaired vascular supply without the presence of arterial occlusion. The incidence of this condition is between 5 to 30% of all mesenteric ischemia cases. And in cardiac arrest patients, it appears between 2 to 6%. The mortality rate is very high, it's between 50 to 93%. Regarding the etiology, the main causes are low cardiac output and vascular spasm. And in cardiac arrest patients, also the no flow and low flow period play a big role. And these conditions could be enhanced by hypovolemia and catecholamines. Ischemia reperfusion injury results in enterocyte dysfunction to intestinal necrosis, and could be more pronounced in patients after cardiac arrest. Pathophysiology of this condition is very interesting, and generally the enterocytes are sensitive to hypoxia and hypoperfusion, and the most sensitive layer is the mucus. Mesenteric vasoconstrictions appears in 10 minutes after onset of hypotension, and is more pronounced if the catecholamines are used. And the reason of this condition relies on anatomical structure of circulation in intestinal villi, where the arteries and the veins flow parallel in the opposite direction. And this structure causes decline in oxygen saturation from the villi base up to its top. Damage of this sensitive layer leads to disruption of intestinal barrier, and consequently bacteria, microbial products and toxins can be released in the circulation, and this condition can amplify the inflammatory response, specifically by production of reactive oxygen species. Regarding the clinical symptoms, there is a problem because early symptoms are frequently missing, and if they are present, they are mostly non-specific. The big role plays, of course, the sedation of these patients after cardiac arrest. But in the advanced stages, we can observe the profuse diarrhea, increased waste from nasogastric tube, gastrointestinal bleeding, abdominal distension, or intestinal necrosis. Regarding the diagnosis of mesenteric ischemia, as I said before, if we have the suspicion in the early phases, we can use the computer tomography or angiography, but the results are mostly effective in the later phases of this condition, and it helps us distinguish between non-occlusive mesenteric ischemia and and occlusive mesenteric ischemia. The problem could bring the contrast medium load, which could precipitate with coronarography contrast media used before, because the cause of cardiac arrest is mostly cardiovascular, and most of these patients have the coronarography at the beginning. The other problem is the hemodynamic instability of these patients. From the other examinations, we can use the endoscopy, of course, and the most promising seems to be biomarkers, even in the early phases. Here you can see the examples of the examination. On the left side is the CT scan with the apparent thickness and swelling of the intestine, which is distended. And on the right side, there is the endoscopy view in the intestine with the hyperemia of mucus and some signs after the bleeding. Biomarkers, as I said before, they are the most promising way how to screen this serious condition. The most promising of them is intestinal fatty acid binding protein, which is the cytosolic protein expressed in the mature enterocytes at the tips of villi. The sensitivity and specificity for the mesenteric ischemia is approximately between 80 and 90%. We can find elevated levels in the serum after cardiac arrest, and in some patients, these levels could have also the prognostic value. The other marker is the citrulline, which is also amino acid. It's produced by enterocyte in the small intestine, and it is used as the functional enterocyte mass marker. The other two biomarkers, D-lactate and endotoxin, are connected with the intestinal barrier damage. D-lactate is used as an indicator of splanchnic hypoperfusion. It is produced by bacteria E. coli in the intestine, and because liver are not able to metabolize D-lactate, it is released in the circulation where it could be detected after the intestinal barrier damage. The endotoxin is the major component of G- bacterial membranes, and it's also released into circulation after the intestinal barrier breakdown. Regarding the papers, there is not much studies yet. Here you can see the recent work of Norway authors showed that the biomarkers of intestine examined in 65 patients after cardiac arrest who achieved ROSC were elevated, and they speculated that they could possibly influence the inflammatory markers after cardiac arrest, specifically interleukin-6, which was confirmed. However, the length of cardiac arrest in these cases was up to 30 minutes. So we can speculate that in the refractory cardiac arrest cases, it could be more pronounced. Another study, older study, examined levels of intestinal fatty acid binding proteins, and in cardiac arrest patients, which was highly elevated at the time of admission. Biomarkers may reflect the severity of ischemia and subsequently the perfusion injury in patients after cardiac arrest, and it could be also connected with some prognostic value, because adverse neurological outcome of patients after cardiac arrest counted around 70% in those who had manifested mesenteric ischemia. Among the risk factors, we count on female sex, baseline lactate over 5 millimoles per liter, low flow period over 17 minutes, and inotropic score over over 7 microgram per kilogram per minute. In those studies, I'm sorry, you can see the prognostic value of the citrulline on the left side, which is highly connected with the prognostic as a prognostic marker. And on the right side, the authors assessed the prognostic value of fatty acid binding protein, which also quite persuaded. Let me introduce the results of our study, Prakovka study, which was presented in JAMA 2022. In brief, it was the monocentric prospective randomized trial comparing the effect of standard CPR approach versus invasive approach, included intra-RS transport and eCPR. We enrolled 256 patients with refractory cardiac arrest, 132 in a standard arm and 124 in an invasive arm. And the intestinal sub-study was performed, and we selected all patients from both arms who survived longer than 1 hour after the hospital admission. Intestinal ischemia perfusion injury assessment was based on a clinical signs, which was the profuse diarrhea, higher nasogastric tube waste, and onset of symptoms so within the 12 hours after admission. And we correlated this presence of intestinal injury with occurrence of neurological unfavorable survival after 6 months. Here you can see the basic characteristic of these patients. You can see that they were almost 60 years old in both arms. The proportion men and women was almost the same, with the higher prevalence of men. Time of cardiac arrest was 46 minutes as a medium, and 58 minutes in a eCPR arm. And finally, the primary neurological outcome in the conservative arm, it was around 22% with a good neurological outcome, and in a hyperinvasive arm around 31%. Here you can see the other parameters which were compared to the appearance of intestinal injury, and only the length of the cardiac arrest was tightly connected with the appearance of the intestinal injury, and subsequently with the neurological outcome of these patients. Out of 256 patients, we observed the clinical manifestation of intestinal injury in 61 patients who survived more than 1 hour after admission. 51% of these patients was treated with an invasive approach, and 16% of these patients were in the standard arm. And we observed the adverse neurological outcome in patients with intestinal ischemia in almost 90% in the invasive arm, and in 60% in a standard arm. And this manifestation of intestinal injury was significantly associated with the poor neurological outcome. Here you can see the results graphically. On the left side, it's a manifestation of ischemia perfusion injury of the intestine regarding the duration of the cardiac arrest. And on the right side, the graph presents the results regarding the neurological outcome. So let me conclude. You can say that the non-occlusive mesenteric ischemia is a serious complication of critical conditions, specifically cardiac arrest. There is a questionable role of biomarkers, specifically intestinal fatty acid binding protein, which could have also the prognostic value. And as we know, there is the difficult diagnosis and treatment, specifically in the early phase, which should be improved in to have then possibility influence the prognosis and the treatment of these patients. And then it could be called as a negative prognostic marker in the patients after cardiac arrest and reflex of severity and ischemia perfusion injury. Thank you.
Hello, everyone. So my topic is comparing triple combination drug therapy and traditional monotherapy for better survival in patients with high-risk hypertension. Hypertension, a widespread health concern globally, is a leading risk factor for cardiovascular diseases, with effective management crucial for reducing associated health burdens. Despite available medications, a significant portion of hypertensive individuals fail to control their blood pressure. Combination therapy, often necessary for blood pressure control, especially with triple combinations, proves more effective than monotherapy or dual combinations. However, many patients still struggle to achieve target blood pressure levels. Another report in the Journal of American Medical Association shows that most hypertension patients have uncontrolled blood pressure despite the widespread availability of effective antihypertensive medications. In most nations, at least 50% of hypertensive patients do not meet the blood pressure objectives that are generally advised. In the United States, according to data from the National Health and Nutrition Examination Survey, between 2011 and 2014, only 53% of adults with hypertension had it under control, and the situation is even more concerning in other nations. Many patients will need 3 antihypertensive medications to reach blood pressure targets, and current recommendations suggest combining medications with complementary modes of action. 3 single pill triple combination medications are on the market, each combining a calcium channel blocker, a diuretic, and an agent that affects the renin-angiotensin-aldosterone pathway, either a direct renin inhibitor or an angiotensin 2 receptor blocker. So the methods that were reserved for this study were search strategy and data extraction. We used the medical databases PubMed, Medline, PubMed, PMC, and ResearchGate, ScienceDirect, Google Scholar, and Cochrane Library to search for relevant full text and peer-reviewed articles. The databases were searched using the predetermined keywords to find the potentially relevant articles. The keywords used in the search included hypertension, triple combination drug therapy, high-risk patients, blood pressure control, and monotherapy. Keywords used were the Boolean and or to obtain results. And the following mesh strategy, as you can see over here, were used to search for the results for the studies over here. So for the eligibility and screening, high-risk hypertension refers to the condition where individuals with hypertension are at higher risk of experiencing complications or adverse health outcomes. This category is defined by the following criteria: a systolic blood pressure more than 180 or a diastolic blood pressure more than 110. The systolic blood pressure represents the top number in the blood pressure reading, where indicating the arteries in the heart, whereas the diastolic blood pressure lower number that shows the pressure in the arteries and the heart is resting between beats. If the diastolic blood pressure is 110 or more, it is considered high risk. Low risk hypertension is defined as atherosclerotic cardiovascular disease or a 10-year cardiovascular disease risk less than 10%, with stage 1 hypertension with a blood pressure of 130 to 139 and diastolic 80 to 89. Low risk hypertension is when individuals with hypertension have a lower risk of complications than those in the high risk category. The following criteria define this category. No ASD. ASD refers to the buildup of plaque in the arteries, which can lead to various cardiovascular problems. If an individual with hypertension has no pre-existing ASD, they're classified as low risk. A 10-year CVD risk of less than 10% with stage 1 hypertension implies that the individual has cardiovascular disease of risk of less than 10% over a span of 10 years. If an individual with stage 1 hypertension with blood pressure ranging from 80 to 89 diastolic has a risk of CVD of less than 10%, they're considered low risk as well. So the inclusion criteria and the exclusion criteria. For the inclusion criteria, the papers published were within 10 years, and the papers written and published in English language, the papers involving human subjects, papers involving both genders, papers focusing on all age groups, papers focused on patients with high-risk hypertension, and papers focused on triple combination drug therapy for patients with high-risk hypertension. And the exclusion criteria as follows: gray literature, papers involving low-risk hypertension patients who underwent triple combination drug therapy, papers with only abstracts available. The selected articles were subjected to quality assessment using the relevant techniques to assess randomized controlled trials. The Cochrane bias assessment tool was used, and to assess observational studies, the Newcastle OTOA tool was used. For systematic reviews, the assessment of multiple systematic reviews of AMSTAR checklist was used. This table shows the quality appraisal tools used to assess bias in the studies. We searched databases from Medline, PubMed, PMC, ScienceDirect, Google Scholar, and Cochrane Library for 206 published papers. There were 50 articles of the duplicates were eliminated, and the articles were filtered based on the inclusion and the exclusion criteria. Only 11 pertinent journal articles were left after screening and eligibility. As you can see from the diagram over here, we first had 206, then after the screen, we had 190, and then exclusion were 141, and we sought for retrieval were 50, and we could not retrieve 29. And then in the end, we were left with 21 and 10, and then 11 studies were included in the review. So we had like a couple of studies over here, as you can see. So Egan et al. 2022. The purpose for this paper was the literature is selectively reviewed and summarized on SPC, especially as initial therapy compared with monotherapy and multiple pill regimens on adherence, hypertension control, clinical outcomes, population impact, and adverse effects. An attempt is made to quantify the relative use of SPC versus monotherapy and free dose combinations in hypertension management. Barriers and potential pathways to greater use of SPC in managing hypertension are explored. There were a number of 250,000 patients in this study and the systematic review, and the evidence, the type of study was a systematic review, and the evidence suggests that the inclusion of antihypertensive SPCs on national formularies and recommendations for the use of SPC in national hypertension guidelines, and ready availability and affordability of SPC in the marketplace improved the uptake of this treatment option. Another study by Pot et al. 2014, PAINT, was principally designed to investigate the antihypertensive efficacy of triple combination of antihypertensive drugs, perinorepal, amlodipine, indipatine, sustained release in patients who had not reached target PP values with previous antihypertensive treatment. As a secondary aim, changes in metabolic parameters were analyzed. The number of patients in this study were 6,088, and the type of study was an observational study. A triple combination of perinorepal, amlodipine, indipatine were controlled blood pressure effectively in hypertensive patients uncontrolled by previous antihypertensive monotherapy or bitherapy, including RAS inhibitor, amlodipine, or RAS inhibitor, or hydrochlorothiazide combinations. Dusing et al. In a study 2017, it has been estimated that 3 and more antihypertensive agents are required in approximately 1/4 to 1/3 of patients. Combining antihypertensive agents from 2 greater blood pressure reduction than doubling the dose of a single agent. In addition, combining drugs with complementary mechanisms of action may provide benefits beyond blood pressure lowering, such as improving tolerability and thus higher rates of adherence with the prescribed medication as compared with increasing a dose of a single agent. The number of patients in this study were more than 500,000, and it was a systematic review. In conclusion, combination therapy, including drugs from classes having complementary action, is advantageous in terms of blood pressure reduction control, particularly in high-risk patients, and may be associated with improved tolerability. Administration of combination therapy as SPC is capable of enhancing treatment adherence. In another study by Lin et al. 2015, resistant hypertension is highly associated with cardiovascular risk. The difficulty in enrolling large number of study participants limits studies on the treatment effects of the RH. This study aims to compare the effectiveness of triple antihypertensive combination therapy for RH patients in Taiwan. The number of patients were 30,551, and it was also RCT. The AC plus D combination therapy seemed more effective than the A plus B plus C therapy in preventing MACE among patients with right hand hypertension. Traditional monotherapy for high-risk hypertension. Hypertension, common blood pressure, most prevalent cardiovascular risk, and extensively researched. Despite the various treatment options, studies have shown that only 40 to 50% of treated hypertension patients are able to achieve recommended treatment objectives. This indicates a significant gap between the desired blood pressure levels and actual control achieved in clinical practice. The introduction of more aggressive therapeutic agents in recent guidelines, such as the 2018 European ESC and ESH and the 2017 American Heart Association and the American College of Cardiology guidelines, further emphasizes the importance of achieving optimal blood pressure control. These guidelines recommend lower SBP levels and between 130 and 120 and DBP levels between 80 and 70 for most high-risk hypertensive patients. Traditional monotherapy involving the use of single antihypertensive drug has been long considered the cornerstone of hypertension treatment due to its cost effectiveness. Several classes of antihypertensive drugs, including angiotensin converting agent, ACE inhibitors, angiotensin receptor blockers, ARBs, calcium channel blockers, diuretics, and beta blockers, commonly used as monotherapy options. However, despite the widespread use of monotherapy, the proportion of uncontrolled hypertensive patients remains substantial. This discrepancy between the recommended treatment options and the actual control achieved suggests the need for reevaluating the current treatment strategies and exploring alternative approaches to improve blood pressure management. Benefits and limitations of traditional monotherapy. Traditional monotherapy involves the use of single antihypertensive drug to regulate blood pressure. The key advantage of its approach is cost effectiveness, as only one medication is used. Additionally, traditional monotherapy is relatively easy to administer and supervise, making it a convenient option for patients. However, despite these advantages, traditional monotherapy has several limitations that need to be considered. One significant limitation is its potential inadequacy in regulating blood pressure controls with complex medical conditions requiring multiple medications. Hypertension is often a multifactorial condition, and some patients may require a combination of drugs to effectively control blood pressure. Using a single antihypertensive drug may not provide sufficient control in these cases. This limitation is particularly relevant for patients with high-risk hypertension, as they often need aggressive blood pressure management to reduce the risk of cardiovascular complications. Another limitation of traditional monotherapy is its limited efficacy in achieving blood pressure. Even at the highest prescribed doses, despite escalating the dosage, many patients with high-risk hypertension do not achieve the desired blood pressure targets with monotherapy alone. This suggests that monotherapy may not be sufficient for all patients. The benefits and limitations of triple combination drug therapy. One of the main advantages of triple medication combination therapy is its superior efficacy compared to conventional monotherapy. Numerous studies have demonstrated that the use of 3 antihypertensive medications in combination leads to a greater reduction in blood pressure levels. This finding is particularly relevant for patients who have failed to achieve target blood pressure goals with monotherapy. By utilizing multiple medications with different mechanisms of control, triple therapy can be effectively target different pathways involved in blood pressure regulation, resulting in better control. Despite its efficacy, triple combination therapy presents several limitations. One notable concern is the increased complexity and the cost associated with administering and monitoring multiple medications simultaneously. The need for patients to take multiple medications can lead to higher treatment costs and may pose challenges in terms of adherence. This is particularly relevant for elderly and frail individuals who have difficulty managing complex medication regimens. These patients may often require additional support and monitoring to ensure adherence and minimize the risk of adverse effects. Another important consideration is the potential difficulty in identifying the adverse effects that can occur with any medication, and the pharmaceutical agents are used in combination. Adverse effects can occur with any medications, and the presence of multiple drugs in a triple combination regimen can complicate the identification of a causative agent. This challenge may hinder the ability to make adjustments or substitutions to optimize therapy and minimize side effects. Better survival with triple combination drug therapy. Several studies have shown that triple combination drug therapy is associated with improved survival in patients with high-risk hypertension. Most of the evidence comes from studies testing valsartan, amlodipine, hydrochlorothiazide, and olmesartan, amlodipine, and hydrochlorothiazide combination. 2 large randomized double-blind controlled trials have shown that these 2 triple combinations promoted blood pressure reductions, thus leading to lower mortality rates. In case of uncontrolled blood pressure despite monotherapy at maximal dose or bitherapy at initial dose, switching to triple therapy or amlodipine, 5 mg or bisoprolol, 5 mg plus perindopril, 5 mg leads to a significant decrease in blood pressure with a p-value of 0.001, an improvement in response treatment, and a better blood pressure control rate with high survival rate. In conclusion, triple combination medicine and conventional monotherapy can impact the survival rate of patients with high-risk hypertension. Compared to a conventional monotherapy, the administration of the triple combination medicine associated with significantly lower risk of death, according to the study's findings. Triple combination medication lower the risk of heart failure, stroke, and other cardiovascular events. This shows that people with higher risk of hypertension may benefit from triple combination medication. While this approach is more expensive and complex than traditional monotherapy, it may be beneficial for patients who cannot achieve their target blood pressure with monotherapy or require multiple medications. Healthcare providers need to weigh the risks and benefits of triple combination therapy when deciding which treatment approach is best for their patients. Thank you for your attention. I'll be happy to take any questions, or you can reach me in my email over here.
So good morning for those in Portugal and good evening from the rest of you. I'm here to talk about our research. I represent the research team in Portugal. We are working with the postmenopausal women in community work in Penafiel city in district of Porto in Portugal's country. Starting
we can see that in postmenopausal woman, there's lots of change, and age is the major change in cardiovascular diseases according to endothelial dysfunction. And for that, we can see that arterial stiffness plays a major role in this, indicating such as arterial stiffness in aorta and carotid arteries. Also, you can see that arterial stiffness can be accessed by many measures and means, but the carotid-femoral pulse wave velocity assessed with the sigma core is still the gold standard, and is the gold standard that we use to access the arterial stiffness of our sample. And we can see also by literature that arterial stiffness correlates independently with blood pressure and with menopause. It contributes with a raise of 2 millimeters of mercury after adjusting for confounding variables. It also works as a clinical indicator to predict future cardiovascular events in this population. It also showed a significant increase over 1 year, and Samar Gandhi presented in the results that in the first year, an increase in 1 meter per second is 1 meter per second, sorry, is an increase in 15% in cardiovascular disease and death. Arterial stiffness and blood pressure, hemodynamics variables, particularly central arterial pressure in menopause, is accelerating with cardiovascular aging, regardless of chronic age. It's also elevated, and endothelial dysfunction is reduced across the stages of menopause, especially early and late, as I present with this study from Harlow. We divided our sample into 2 groups, the early, since amenorrhea to 8 years after amenorrhea, and the second one, the late postmenopausal group until lifespan. Our study has the main purpose to investigate the influence of age and menopause stage, early and late, and blood pressure on arterial stiffness of this specific population. This is a cross-sectional study of a major one, and this involved in a community program called the Menos Pausa Mais Movimento. Translating is Let's Pause and More Movement. This is hosted by the City Hall in Penafiel, and we have 65 women assessed for this study. They were in 35 of them were in early postmenopausal group and 30 in the postmenopausal group. They mainly have natural and not using hormone therapy. Inclusion criteria was with women after 35 years old of age or older, confirmed menopause, not using beta blockers or antiarrhythmic. Besides this cross-sectional, we have a longitudinal one, and this main purpose is connected with the exercise program, so it could influence the exercise program and results during and after the exercise program. They also have the absence of premature menopause and not symptoms for angina, myocardial infarction. For hemodynamics, we use blood pressure measured by OMRAN, and the arterial stiffness, especially carotid femoral pulse wave velocity, was accessed with the sigma core and core. For that, in their appointments, women were asked previously at these appointments to fast for 4 hours, abstain from caffeine, tea, and also alcohol for at least 8 hours, and from exercise in the previous 24 hours before the tests. Especially for these hemodynamics, they were performed with a single trained researcher, in this case me, and period measurements, participants rest in supine position on an observation table for 10 minutes within a quiet temperature, in a quiet temperature and control room with more or less 24 degrees and 50% of humidity. Also, for blood pressure, it was taken at least 2 measurements with 1 minute apart, and every time we saw disparity between measures superior to 2 millimeters of mercury, another measure should be taken. And after that, between the two closest measures were recorded at final systolic and diastolic blood pressure. For arterial stiffness, according as the previous one, after 10 minutes in supine position, the carotid femoral pulsal velocity was assessed using applanation tonometry. And data was registered during at least 2 respiratory cycles, about 10 to 12 seconds. Sorry. Consecutive pressure waves were recorded at carotid right side and femoral right side arteries, accompanied by simultaneous electrocardiogram, and the electrocardiogram provided a reference for using the foot-to-foot method. For statistical analysis with IBM SPS, with a statistical significance level of 0.05, we used also stepwise multiple regression analysis, and the man-Whitney test also used cluster analysis for including, in this case, the age for younger and older postmenopausal women. In our descriptive analysis, we saw that both the hemodynamics for systolic, diastolic, and arterial stiffness were in average in normal levels, but for body mass index, they presented obese level considered after 25.5 kilograms per square meter. In general, 80% of women presented no use of hormone therapy, so these results we are achieving have no influence with this kind of therapy, and also 88% presented nature menopause, also responsible for these clean results we are showing. In average, we saw that carotid femoral pulse wave velocity were above the 10 meters per second. This is the cut point that was set by literature, but in 15% of the postmenopausal women was present high level. So this is an important measure because every time there is an increase, as I said earlier, because of literature, we saw that 1 meter per second is responsible for 15% of increase in mortality in this population. After adjusting the levels, we saw that the systolic blood pressure and age, after stepwise multiple regression analysis, were correlated with arterial stiffness. In this case, we have to use another cluster analysis for age for younger women in postmenopause and older ones. And we can see that there's a statistical difference and significant difference between systolic blood pressure and above and under and above, sorry, 120 millimeters of mercury, and for younger and older women in our group. In conclusion, regardless of menopausal stage, both age and systolic blood pressure are influential factors contributing to increased arterial stiffness in this specific population. We want to thank you all the participants and the medical staff that work with us in the primary health centers in this city, and for the university also in Portugal to allow us to using Sigma Core at Core. This is the end of first presentation. This is my email. If someone has any question, can contact me. I will try to speak slow. Sorry, I was watching for the time, but I believe we have time. And this is the part of our longitudinal study. So the intervention after the exercise, and this is the same population. So I'm presenting now the effects of after 3 months of work, for 4 months, sorry, 4 months of multi-component green exercise program. In this multi-component, we had both cardiorespiratory workout and resistance workout. And as we can see by the literature, in this postmenopausal stage, there's a lot of change in the women body with an escalation in fat mass, especially in the visceral fat mass, alongside with the decrease in muscle, especially muscle mass, and it is very important to achieve normal levels for a level of health condition in this case. Sorry. After that, women, there's an increase not only in the muscle strength, but also cardiorespiratory fitness. That's also included in our sample and assessments. Also, age-related weight gain introduced other issues, notable metabolic change. In this case, metabolic syndrome is also present in this kind of population with the distribution of central and visceral effect, according to literature. Physical activity plays also a crucial role in physical function and in middle-aged women, and the high level of physical activity is correlated with better physical performance and muscle mass among postmenopausal women aged between 47 and 55 years old. Literature also shows evidence of a positive association between urban green spaces, especially this kind of space that we use because it's in the middle of the city, and the physical activity and body composition, and especially a negative association with mortality and cardiovascular markers. These kinds of exercise problems, both cardiorespiratory and strength resistant, can lead to improvements, especially in mineral bone density, strength, flexibility, balance, functional fitness, and especially in quality of life, reducing in this case the risk of falls and the dependence that comes next. This study examined the impact of multimodal green exercise program on the physical fitness components of postmenopausal women. There were 80 women, in this case, in our study. 55 was in the exercise group and 25 in the control group. According to the study, because it's in the same city program, the sample was the same, and the criteria was also the same, with age at least 45 years or older, confirmed menopause, no use of beta blockers or antiarrhythmic medication because of exercise program, absence of premature menopause, and no symptoms of angina or myocardial infarction in the last 3 months previous the study. In the assessments, we use in-body to access body weight, fat mass, visceral fat level, appendicular muscle mass, the ergometric monarch for cardiorespiratory fitness. In this case, we use especially the YMCA test. That's a submaximal test that allows us to rate by estimating maximal oxygen consumption, and it provides a safer exercise mode compared to a treadmill, as there's a reduced risk of falling, and there's no need of more biomechanical improvements, but use this kind of equipment. Participants were required in this kind of assessment to complete 2 separate workloads at least, and it was imperative that participants maintain the pedal rate of 15 revolutions per minute. We also used the JAMAR digital dynamometer for hand grip strength and a stadiometer for body weight. In statistical analysis, we use also a p-level lower than 0.05, absolute and relative change, independent sample t-tests, and the mean-white test. The exercise program was performed during 16 weeks. It was again multimodal exercise program with the strength exercise applied in the proper installations with the resistance bands mostly, and the green multimodal also because it was in the center of the city, in the natural area, presented there. It was in 3 non-consecutive days per week with at least 60 minutes per session. The resistance workout was composed by 3 sets with more or less 15 to 20 repetitions, starting with 40% of heart rate reservation and in the last microcycle with 70% of heart rate reservation. We have at least 15 minutes and a maximum average of 20 minutes for this part of the workout, and the rest with a cardiorespiratory workout of an average of 30 minutes, starting also in the first microcycles with a 40% of heart rate reservation and in the final microcycle with a 75% of the heart rate. It was imperative that the sequence was exactly like this: first resistance workout and then cardiorespiratory fitness. Otherwise, if we change the order, it will interfere with the resistance workout and will decline with the muscle improvements. In this population, 92% also had natural menopause, and 77% do not reported use of hormone therapy. In this case, 78%, great part of our sample, presented excess of fat mass. In this case, was set above 35% of the body, and in this case, 83% presented excess of visceral fat level. The set point was cut point was set above 9 points. When we analyze the relative and absolute change, we can see that at start point there are no statistical difference between the groups, but after the 16 weeks of workout, we have a big difference between the body mass in the exercise group compared to the previous test, with a significant P level, also in body fat, visceral fat, and cardiorespiratory fitness, with great improvements compared to those that remained in the control group. This study provides evidence that the 16-week multi-component green exercise program was successful in improving adiposity levels and cardiorespiratory fitness among postmenopausal women. We also have previous results according to arterial stiffness in this population after the exercise program intervention, and we also saw until the moment that there are improvements in arterial stiffness with this kind of exercise program, indicating that that can be helpful in improving health in this kind of population. We also want to thank the participations and the healthcare center staff for allowing us to work with this kind of sample, and the University of Portugal for the allowing us to use the Sigma at core. Thank you again for your attention.
Good morning, everyone. Thank you for the invitation to the second World Congress on the Heart and Cardiovascular Disease. My name is Elias Gallardo Navarro. I'm resident surgeon at the Spanish Hospital in the Mexico City. The following case is published in the Journal of Angiology of Spain. The title, Unilateral Pleural Effusion After Spontaneous Migration of the Portal Cath to the Left Hemithorax. Introduction. Subcutaneous infusion port represents a valued method for the long-term chemotherapy. They have advantages over other venous access methods, such as the ease of placing them under local anesthesia and on an outpatient basis. Implantable catheter system with subcutaneous reservoir. For a cath, use a permanent vascular access for the chemotherapy administration. This product consists of a flexible silicone or polyurethane catheter attached to the titanium portal reservoir. which is implanted subcutaneously in the anterior wall on the thorax over the aponeurosis of the pectoralis major muscle, so that the tip on the catheter is in the superior vena cava of the right atrium. This surgical technique is not free of complications, 18 period 3%, and the postoperative hematoma is the most frequently observed early complication, followed by catheter infection, thrombosis, necrosis of the surgical pocket, capsular resection, and catheter migration. Case report. A 41-year-old woman diagnosed with a right breast carcinoma. On March 24 the last year, a cath catheter was placed for the administration of the chemotherapy through the left subclane being using the standard Sellinger technique. In this procedure, it should be noted that upon placing the dilator, it was detected that the tip was naked, making it difficult to pass the gadware in the veins, and which achieved at the second attempt. However, transoperative radiographic control was performed by fluoroscopy, which corroborated the head of the catheter tip in the superior vena cava without immediately mobility. This picture is the proper placement of the catheter tip in the superior vena cava, and the patient was discharged the same day in the good condition. 7 days after her admission to the hospital, she went to the emergency room because she expressed a clinical symptom of the 4 days of evolution with oppressive, progressive extended pain in the left hemithorax that radiated to the ipsilateral neck and shoulder and did not improve with analgesic. She did not present any respiratory distress at any time. During the interrogation, the patient reported arcing and frank vomiting on the 4 occasions during the 20 hours after surgery in relation to the anesthesia. She also reported exacerbation of symptoms after the administration of the first cycle doxorubicin-based chemotherapy. Laboratory studies were performed in the emergency room, blood count, complete serum electrolytes, and blood chemistry without any abnormalities. She denied any symptom of respiratory distress. Her vital signs were stable: blood pressure, pulse, respiratory rate, and temperature. A chest X-ray was taken, which revealed migration from the tip of the catheter to the mediastinum and the left hemithorax, accompanied by the pleural effusion and pneumothorax. Subsequently, a simple computed tomography scan was performed, which confirmed the migration of the tip of the port catheter to the left hemithorax, accompanied by the pleural effusion approximately 30% and pneumothorax approximately 3%. This picture, simply CT scan on the chest axial section, showing the red arrow the trajectory of the catheter in the ipsilateral hemithorax. With these findings, the surgical procedure was performed on the same day, with a consistent thoracoscopy of the left hemithorax for the removal and lavage of the pleural effusion, together with a continuous oxygen therapy and analgesia. In this picture, the display catheter in the left hemithorax is evident, and the same and the thoracoscopy showing the hole in the mediastinum. Immediately, clinical improvement was reported after catheter removal. The patient was discharged from the hospital after 22 hours. Is a good clinical condition without presenting any eventualities. Discussions. A central vascular access is important for the patients who need to receive medical cancer treatment. It's a common procedure nowadays that are relating to greater comfort for the patient. Signs: once is the surgical insert, I can be used several times conveniently. However, it's not without complications. In this study is a retrospective, and the 3,000 patients, the placement of the type of catheter was associated with an overall complication rate of 11.8%. And this article can be divided in the early and the late complication. The former can include arterial puncture, malposition, pneumothorax or hemothorax. Infection and catheter thrombosis are the more frequent in late complications. And in contrast, and spontaneous catheter tip migrations is reported as a common complication. The internal jugular vein homolateral to the implant in the most common site of migration. Overall, the physiopathology is unclear. Perforation of the blood vessel wall is related to the large size and inflexibility of the cath of catheter tip. We resist the vessel wall, causing damage to the intima with mechanical irritation forces. Some factors can contribute to the catheter migration, such as encourage early resist during the get-wear insertion, as this could be a clue and the entering of the vessels and the stiff angle, and the paper the surgeon insert the lead deeply. An important factor is the change of position of activities such as weightlifting to the required extremist valsalva maneuvers that can cause catheter migration. In this article, the risk factor as a possible mechanism and intravenous for catheter migration. The theory increasing intrathoracic pressure is in lung disease such as in lung cancer have a higher incidence of catheter tip migration than in other types of cancer, due to constant increase in pressure that can lead to a temporary reversal of thoracic blood flow, thus causing catheter displacement. In this article, the symptoms relating to the poor catheter tip migration can be varied. A symptomatic patient has been reported, and some report cervical symptoms, shoulder homolateral pin pain, or revolve the leather being reported in all patients. Overall, there is imaging evidence of the proper position of the central catheter. A complication should be suspected when there is vascular perforation and the pleural effusion associated with respiratory failure on the hemodynamic instability. Likewise, in the case of cancer patients, the patency of the line must be corroborated before any intravenous treatment. Conclusion: spontaneous migration of the reservoir catheter tip is described in the literature as an infrequently complication, may be asymptomatic the first few days, and they may be associated with several secondary lesions. It is not taken into account and timely diagnosis and treatment is not carried out. Thank you all for your time, and if I can answer any question, my email is below in this. Thank you very much.
I'm an intern medicine resident here in Mexico. I will talk about a case report of a cardiac myxoma that we see here in our hospital. So my hospital is the General Hospital of Morelia, named Dr. Miguel Silva here in Mexico. Well, I will begin with the case. Well, first of all, with the case presentation is a 39-year-old Hispanic female, which it has without medical history of chronic diseases. She began 2 years ago with her symptoms of dyspnea grade 2, according to the NYHA Association, and dry cough. She went to a doctor, and she was treated with a beta blocker with the relief of the symptoms. After that, until 2 months ago, she underwent a laparoscopic cholecystectomy, and she began again with symptoms. Few days after the procedure, she began with she noted shortness of breath, ankle sweating, and lipectomy after physical activities. Here in the initial physical exam, when we treated here in the urgency department, we saw that she had a jugular ingurgitation grade 3 to 4, lungs with bilateral wheezing, bilateral pleural effusion syndrome with left side predominance, elevation of the heart rate between 2011 rate per minute, elevation of the heart rate, the cardiac murmur in mitral foci and lower extremities with symmetric edema. After that, well, here it is electrical EKG, in which we can see the presence of sinus tachycardia with electric axis to the right and mitral P-way determine the left atrial enlargement. After this, we did a transthoracic echocardiogram according to the algorithms of these heart failure. We see it as a heart failure. Here is the first echocardiogram with in 3 chambers, in which we can see a mass, a solid mass that is protruding to that is in the left atrial and is protruding to the left ventricle. And here it is another. Okay. And after that, I'm sorry. After that, we did a Doppler echocardiogram, in which we can see that this mass that is protruding to the left ventricle is causing the feedback of the blood, which can explain the heart failure that when the patient come to the hospital. We can see it here and also here. That is protruding. Well, the transthoracic report reports that the ejection fraction was preserved, but there was a mass in the left atrium of approximately 52 per and 2009 millimeters in systole, with a slight protrusion into the anterior mitral valve leaflet and left ventricle during diastole, producing severe mitral stenosis. A concentric remodeling of the left ventricle without mobility alterations and both atriums with normal size was observed. Here we also did a CMR, in which the CMR we can see in the SSFP stage, we can see a mass that is mainly completely occupying all the left atrium, and that is protruding to the left ventricle and also affecting the mitral valve. In the T1 phase, we can see a hypodense mass, which is also we have to remember that the T1 we see edema mainly, and this can help us to know that this mass is mainly composed of liquid, which is important in order to, mainly in the CMR situations, to identify that it's a mass and not a thrombus, because it is really important in these cases to be sure that it's not a thrombus. In this case, the mass is really high, it's really big, so we can see that is mainly a mass. Here we have in the steer stage, which is we are showing a hyperdense mass, which mainly show us that is a liquid mass. And here we have a late enhancement phase, which we have to remember that in the late enhancement phase, we can see it can show us about fibrosis or calcification in this case. And here in the upper side of the mass, we can see that it is more late enhancement. Here, well, about the discussion, we have first that the cardiac myxoma is a neoplasm composed of estolate to plum cytological blend, which is mainly of mesenchymal cells set in the myxoma stroma. These type of tumors are mainly composed of multipotent mesenchyma, and as the cells are originated from the totipotential subendothelial cells, which have vascular structures, and these also help us to know that because of these vascular structures, we can see that the symptoms can have symptoms of constitutional symptoms because of the cytosines that are secreted because of these cells. First of all, the cardiac mass. We can divide if we see a cardiac mass in the CMR or the TTE, we have to divide it between the tumor, thrombus, vegetation, and other structural situations. The first of all, when we talk about tumors, we have to consider that the 90% of the tumors that are seen in the heart are benign, and they are not mainly primary. They are secondary masses. The primary masses usually are from the lungs or from the ovaries. Just 10% of all these tumors are malignant. The thrombus, well, we can see that most of cases, when we see a mass that is mobile, that with the late enhancement, it don't have a late enhancement, we can think about that is a thrombus. Here in the vegetations, well, we can see mainly of endocarditis mainly, and the structural, well, we can see another types of situations. About the tumor, we can see that there are different kinds of tumors. Mainly the primary, well, we have 90% are benign and 10% are malignant. It is very important to divide it between the patient age, between pediatric and adult age. Between the pediatrics, the 45% are mainly rhabdomyoma, and in adults, between the 45 and the 50% are myxomas. And well, you have the location. It is very important because in this case, in our case, it was a classical case in which we found the cardiac myxoma in the left atrium. Between the 75 and 85%, they are present in the left atrium, arising from the interarterial septum of the fossa ovalis border. 22% are from the right atrium and 2% in the ventricles. Just 1% are present in the valves. The presentation, it is important because it is at all ages, but mainly they are present in between the 4th and 6th decade of the life. Also, for this case, it is important to know that the female it has a female prediction between the ratio 3 to 1. This is important because, well, in our case, it was a female with 36 years. She began with symptoms of heart failure. Something important is that 2 years ago, she began with all these symptoms, but after she began to use the beta blocker, all these symptoms were reduced. Why? Because all these beta blockers, what they do, they reduce the time. They reduce they help in the recharge of the heart, which mainly gives some time to have a better to have more time in the diastole to compensate all the heart failure. And well, here the clinical characteristics. The cardiac myxoma has a classical triad, which is first the cardiac obstruction. It is the most important, and we can see it here in our patient. First, the cardiac obstruction, which can mimic a mitral or tricuspid valve stenosis. In this case, in this patient, we can, if we didn't have the echocardiogram, we can see, well, and we can see all the mass. It can mimic a mitral stenosis. Why? Because the mass was protruding to the left ventricle and was was although stenosis can do a regurgitation of the mitral valve, because the mass was protruding and was conditioning effect between the valve, so that we have all these regurgitation of the blood. Also, another classical triad is the cerebral or the peripheral embolism. This is conditioned between mainly because of a bilious surface myxoma that is degraded, and all these masses works as a thrombus and conditioning all these cerebral or peripheral embolism. Mainly, these patients can be present with a stroke. It is not the most common. The most common symptoms mainly are the cardiac obstruction, which is also combined with the constitutional symptoms, which is fever, loss of weight loss, mainly asthenia, adynamia, mainly, okay? And the diagnostic tools. The role of the advanced cardiac imaging modalities, the first of the algorithm is the advanced echocardiography. And we can see that this is to assess size, morphology, attachment to the adjacent structures, to the extension and the hemodynamic effects. This is to improve intracavity definition, assess the vascularity, and exclude thrombus. This is the most important. Here in our case, the mass was big, so we can be sure, mostly, that it was not about a thrombus. The cardiac magnetic resonance is the golden standard for these kinds of structures, because it we can assess morphology, dimensions, location, extension, homogeneity, infiltration into the adjacent tissue, like the late enhancement. And this is very important because we also can characterize the histopathology and not taking a cardiac biopsy, because we know how the high risk of taking a cardiac biopsy. And with the CMR, we have these kind of help that we don't have to be that aggressive with the patient. The computed tomography is to assess calcified masses, but it is not well, if we don't have CMR, we can use it, and it can help us to be more sure that it's not about a thrombus, but a mass. And the positron emission tomography. Talking about in our media, here in Mexico, it is difficult to have this kind of the positron emission tomography. Mainly here in the public hospitals, it is very difficult to the doctors and also to the patients to have this kind of materials. So we can use, or we have mainly the transthoracic echocardiogram and the cardiac magnetic resonance. And that's all. And here is my biography.
Добрый день, дорогие друзья. Good afternoon, dear colleagues. First of all, I want to express my gratitude to the organizer of this wonderful Congress for the invitation. I wish everyone fruitful work and excellent health. A few words about our hospital. This is a level 3 perinatal center, one of the 5 perinatal center in Moscow region. It is only Moscow region because in Moscow city there are many more than in Moscow region. Our perinatal center provides obstetric care to patients in the south of the Moscow region. This is south of Moscow region, and here we have several small towns with population about 1.2 million people, and in this region we have about 11,000 births a year, and in our hospital, there is about 6 or 7,000 births an year. And as throughout the world, in our country, in the Russian Federation, the struggle continues to both increase the birth rate and reduce maternal mortality. In February 2023, WHO published a report on maternal mortality between 2000 and 2020, which indicated that while progress had been made in reducing maternal mortality from 20,000 to 2015, progress had been made in many countries between 2016 and 2020 faded away. Overall, the global maternal mortality rate in 2020 was estimated at 223 maternal deaths per 100 live births and is stagnating. Every 2 minutes, a woman dies from complications related to pregnancy or childbirth. The main reason is bleeding, 94%. We can say with confidence that this is due to an increase in cases of abnormal placentation. This pathology takes on the characteristics of an epidemic. It has all the signs of an epidemic. If in 1955, disorders occurred in 0.4 per 100,000 live births, then in 2020, it increased of more than 90 times, and their frequency continues to increase. This is clearly seen in the example of our hospital. If in 2015 there were only 15 patients with past disorders, then in recent years there have been about 50. In the first 3 months of 2024, there are already 24 patients. We use our own surgical technique developed in our hospital, which allowed us to reduce the volume of blood loss to 1,000 milliliters and perform organ-saving operations. During this period, we operated on 330 patients with this severe pathology and only 8 cases of hysterectomies, and is about 2.5%. But unfortunately, the amount of blood loss during past disorders is completely unpredictable, and blood loss can be fatal. For example, according to 14 cohort studies, the result of which were published in 2017, the volume of blood loss in past disorders is 100% close to massive. According to this meta-analysis, maternal mortality in the United States with this pathology was about 1%, and in other countries it reached 6%. The average blood loss was about 3,000, and in 13%, a blood loss of more than 10 liters was recorded. Infection complications were recorded in 32% of cases, and in the post-operative period, various complications developed in the patients in 16% of cases. And the sad fact is that in 89.7% when diagnosing placenta creta, peripartum hysterectomy is performed. A study of Latin American colleagues published in 2021 82 maternal deaths within 5 years in 16 countries on 3 continents, including when bleeding was an indirect cause of this. In this international multi-center study, 338 women with PASS undergoing cesarean delivery were included. 14 European and 1 USA center provided cases treated respectively between 28 and 2014 and respectively from 2014 to 2019. Peripartum blood loss was estimated visually and or by weighting and measuring of volume. Participants were grouped based on blood loss above or below 3,500 milliliters and the 5,500 milliliters. Results. Placenta picreta was found in 58% of cases. Median blood loss was 2,000 milliliters. Unplanned hysterectomy was associated with an increased risk of blood loss more than 3,500 milliliters when compared with planned. Blood loss more than 3,500 milliliters was less common in patients undergoing successful conservative management, but was more common in patients who required delayed hysterectomy. Arterial occlusion method, application of uterotonic medication or tranexamic acid showed no significant effect on blood loss more than 3,500 milliliters. More than half of the cases required massive intraoperative blood transfusion, more than 4 units. A retrospective analysis of 313 cases of PASS disorders in the Vidnovsky Perinatal Center showed comparable volume of blood loss in comparison with the previously shown multi-center study. But the volume of FFP transfusions was significantly less, with comparable blood losses. Transfusion of more than 2 units of donor FFP was only 8%. This is due to the practice of preoperative procurement of autoplasma in patients with PASS disorders. In general, 76% of patients were operated on without the use of donor plasma. The effectiveness of using perioperative autoplasma in patients with massive blood loss is especially clearly visible. When the median blood loss is above 50% of the blood volume, the median transfusion of donor plasma is less than 1.5 units. Why are we raising the issue of reducing the number on transfusion of donor FFP? Because there are a large number of potential fatal complications from transfusion of donor FFP. There include non-immunological, immediate immunological complications and delayed immunological reactions, and especially delayed immunological reaction associated with the formation of transfusion-related immunomodulation syndrome. This syndrome causes an increase in infections complications and the incidence of cancer. In addition to the increased risk of infection complication, there remains the risk of direct transmission of infection from donor to recipient. When transfusing donor plasma, infection with hepatitis B, C, HIV, syphilis, T-cell lymphoma virus, prion protein, and so on is possible. various herpes viruses about which we still know little, including herpes simplex virus type 1 and 2, Epstein-Barr virus, cytomegalovirus, human herpes virus type 6. There are 29 known human pathogens. In the Russian Federation, as in most other countries, donors are screened for only 4 types of infection: hepatitis B virus, hepatitis C virus, human immunodeficiency virus, and syphilis. But due to the existence of a seronegative period, the risk of transmission of the types of infection exists. It was previously believed that the cell-free nature of fresh frozen plasma eliminated the transmission of certain disease and the immunogenicity of blood. This has now been shown to be possible. Leukodepletion does not completely eliminate the risk of developing this complication. Meanwhile, studies by Russian authors show that 13.4% of donors have an active form of cytomegalovirus infection, including signs of active cytomegalovirus infection are detected in the subgroups of seronegative donors, about 10.3%. The number of donors with max of active Epstein-Barr virus infection is 12.1%. This indicates a high risk of infection for our patients and their future children. In this situation, the solution of the problem may be the use of autoplasma. When conducting a search in any available medical database, for example in PubMed, we're using this search query since 20,000. You can find 563 publications relating to auto-donation of blood components, but mainly this publication relate to cardiovascular surgery or orthopedics, and only 5 publications during this period relate to obstetrics, and they deal with autologic whole blood. In our practice, we estimate the estimated volume of autoplasma by the degree of placental invasion based on ultrasound science. If it is accreta, then it is enough to prepare 500 milliliters of autoplasma. For increta, 1,000 milliliters, and for percreta, as a rule, 1,500 or 2,000 milliliters of autoplasma. In case of volumetric autoplasma donation in pregnant women before surgery, it may be complicated by massive blood loss. The problem may be the possibility of a decrease in hemostatic potential due to the loss of blood coagulation factors. But after studying this problem, we saw that this does not happen. A slight decrease in fibrinogen concentration and an increase in activated thromboplastin time were not clinically significant. Although the decrease in fibrinogen concentration after plasma collection was reflected in the thromboelastography parameters, the maximum amplitude was low after plasma collection in comparison with the control group, in which autoplasma collection was not carried out. After preparing autoplasma, fibrinolysis is activated, and we practically do not see activation of fibrinolysis and the end of pregnancy, but the activity of plasma hemostasis increased after preparation. The most important thing is that all indicators remained within normal values and did not affect the amount of intraoperative blood loss. We compared patients 254 people who were operated on by one surgeon using one technique adopted in our hospital. In the first group, preoperative preparation of autoplasma was carried out. In the second, not. There were no differences in the amount of the intraoperative blood loss. The group did not differ in hemoglobin levels at discharge, but the median volume of donor FFP transfusion was significantly higher in the group of patients without preoperative autoplasma donation. When comparing thought donor FFP and autoplasma from pregnant women, they do not differ in the activity of antithrombin 3, but the concentration of fibrinogen in autoplasma from pregnant women is much higher, and the clinical effect is better. Here are thromboelastograms of 2 patients operated on for placenta crita. In the first and the second cases, there were comparable blood losses, about 50% of circulation blood volume. The top row is thromboelastograms of a patient who was infused with donor FFP for about 5 doses. After 5 doses, normal coagulation was not achieved, and after transfusion of autoplasma with approximately the same level of hypercoagulation, we achieved normal coagulation. And also after autoplasma transfusion, we see a moderate activation of fibrinolysis, which can also be regarded as a positive thing that prevents excessive thrombus formation. The main problem that arises when using autoplasma donation in obstetric patients is the inability to accurately predict the volume of blood loss and the need for autoplasma. As a rule, the amount of harvested autoplasma exceeds the need for it. In this regard, the question of disposal of large amounts of plasma and the question of the profitability of using this technology in obstetrics may certainly arise. But firstly, when it comes to the health of young patients, we have the issue of cost effectiveness should give way to safety and effectiveness. And secondly, the preparation of 1 liter of plasma by membrane plasmapheresis using the Russian hemophilia device costs 18,000 rubles or about $200. 1 liter of pathogen reduced donor FFP in Moscow region of Russian Federation costs 56,000 rubles or about $650. Thus, the use of autoplasma is more profitable even without taking into account the cost of treating possible complication of donor transfusion. In general, in the long-term improvement in the quality of the obstetric care is associated with the decrease in the frequency of passive blood loss. We must strive to reduce the volume of donor blood transfusion. Transfusion of donor blood components must be performed according to strict indication using modern tests that confirm this need. We should consider increasing the use of autological blood components, and the more economical use of resources will be facilitated by the development and implementation of methods for predicting blood loss and blood transfusion, donor blood transfusion. Thank you for your attention.
Good morning, good afternoon to everybody. I am Kiriana Boldareva, junior researcher radiologist from the Bakalov National Medical Research Center for Cardiovascular Surgery, Russian Federation, Moscow. First of all, I would like to express my gratitude to the All Organization Committee on the behalf of all the authors of this work to represent our presentation of dynamic myocardial perfusion imaging in patients with obstructive coronary artery disease today on this Heart and Cardiovascular Congress. So first of all, I would like to start that the cardiovascular disease are still in the leading cause of the death globally. So they produce women's health and economic burdens. If you have a look to the slide, you will see the age-standardized global rates of cardiovascular disease mortality per 100,000 people, both sexes, and the age-standardized global prevalence rates of cardiovascular disease per 100,000, both sexes, according to the American Heart Association. And in recent years, computed tomography angiography has become a robust and accurate and therefore widely implemented non-invasive method for the assessment of coronary artery disease in patients with a low intermediate cardiovascular risk profile. So advances in computed tomography imaging technology and functional assessment of the coronary bed in patients with a coronary artery disease contributes to the uprise of the CT myocardial perfusion. And just because non-invasive testing plays a pivotal role in the diagnosis, assessment of progression, and also response to the therapy and risk classification of the coronary artery disease, the Society of Cardiovascular Computed Tomography in 2020 summarized the accumulated evidence in such called consensus document and added CT perfusion to all of these experts' documents. So the objectives of our study is that's why the evaluation, the accurate assessment of global and regional myocardial blood flow obtained by dynamic myocardial computed tomography perfusion with a pharmacological load in patients with hemodynamically significant coronary artery stenosis. It means more than 50% of stenosis. And the second one is to determine the diagnostic accuracy and optimal diagnostic cutoff values for the global and regional indicators of stress myocardial blood flow. In our study, we get the 50 patients. So now you see the total characteristic of all the patients on this slide. So the ages and their heart rhythm disturbance. Also, we can see the amount of the patient with diabetes mellitus, with the hypertension, or the patient with the left ventricle hypertrophy. Also we just added here the history of the stent placement and right dominant coronary system, and of course we can't get against smoking. The design of our work was just divided into two groups. So first of all, the patient deviation. The first group of patients were the patient with the coronary artery diseases, so the stenosis less than 50%. It was like so-called the control group, and the amount of patients it was 10. And the second group, there were the patient with the coronary artery disease, more than 50% the amount of stenosis, and in this group we add the 40 patients. And also we have subdivided the patient according to their vessels pathology. So the first group patients with the coronary artery disease also less than 50%, and in this case we have the control group with a 79 amount of the vessels, and the second group patient with the cardiac artery disease more or just even 50% of the stenosis, and the amount of patient was 71. So the main quantitative parameters was stress myocardial blood flow and the global patient and regional levels vessels. So the method, all patients underwent invasive coronary angiography and before their CT. So it was approximately within 8 months. The dynamic myocardial compute tomography, perfusion, and coronary CT angio was performed on the dual source CT scanner in our institution in the Somerton Force Siemens Healthcare. Tomography, and a standard stress rest protocol was used for all the patients. So intravenous infusion of the contrast value, in our case it was the Omnipag, using a patient waist tailor contrast material dose protocol, and also using 2-piece tubing system injectors. In our case it was the Ulrich. So pharmacological loading is carried out with the vasodilating drug. So in our case it was the adenosine triphosphate solution at the rate of 140 milligrams per kilogram per minute, and it was administered using an effusion syringe pump. So intravenously duration 6 minutes. So as you see here, we just first perform the calcium scoring, then we perform the CT angio, then we have the 15 minutes rest, and introduce, in that case 6 minutes, we introduce the adenosine triphosphate solution at the rate I say before. Then we perform stress CT perfusion, so the contrast agents at 5 minutes, and then we have 15 minutes rest, and again contrast agent, and we perform this dynamic CT perfusion rest. There are the parameters of scanning of coronary arteries according to our standard protocol using in our institution. So we use the retrospective ECG synchronization. The tube rotation is approximately 0.25 seconds, and the scan time of CT angio of coronary artery at our patient was 4 ± 7 seconds. And the second slide is about the dynamic myocardial perfusion scanning parameters. So here we see that we used so-called shuttle mode. So the parameters of dynamic scanning of myocardial perfusion are also presented on the slide. We make this combined myocardial carriage volume approximately 10.5 centimeters. And after we just perform all the scanning, so we made the post-processing, and for the dynamic CT perfusion, you know that the qualitative and quantitative measurements are possible. So post-processing was produced on the Syngavia workstation in image processing programs such as CT cardiac, CT myocardial perfusion, and CT cardiac function. And now we will talk a little, so just how we perform it. Of course, CT cardiac is usual for everyone, but now my presentation is about the perfusion. So imaging processing in CT myocardial perfusion program consists of 5 consequent stages. So the first stage was motion corrections, then segmentation, then we do determination of ascending and descending aorta for contrasting the time attenuative curve, and then we perform the preliminary assessment of color map. And so the last stage of post-processing is so-called manual segmentation of left ventricle myocardium according to the 17th segment of American Heart Association. So automatically, as you've seen on the table, the quantitative indicators of blood were calculated to the entire, just a second, I would like to show you the video, to the entire left ventricle and in all selected regions, as I said, in 17 segments of the heart. And quantitative assessment we perform in cardiac function post-process. So using color maps according to this segmentation of left ventricle, we just do the measurement, and here you see their mode and the type of the segmentation. So what are the results? So as a result, we get our statistics data, and we obtain a significant relationship between the regional perfusion parameters and the size of stenosis in coronary artery. And one more significant result, that there was a difference of stress myocardial blood flow on the global level, I mean the whole left ventricle, between two groups of patients. So yeah, the patient of the control group and the patient with the coronary artery disease. And also we have the average value of stress myocardial blood flow in control group. So it was approximately 171 against the opposite group with the coronary artery disease, which was the 144 values. So the p-values less than 0.001. And on regional level, we have the stress myocardial blood flow in control group. The value is 153. And in patient with the coronary artery disease, the value was 134. And also we have the optimal cutoff value of the stress myocardial flow for identification of coronary artery stenosis more than 50% on global level. And the value was 154 milliliters per 100 milliliter per minute, with the sensitivity, specificity, positive and negative predictive value of 90, 75, 47 and 96% respectively. And on regional level it was 144 milliliters per minute, and also with the sensitivity, specificity, positivity and negative predictive value 72, 73, 74 and 69%. So in conclusion, I want to mention that global stress myocardial flow is more sensitive than regional one in detection of obstructive coronary artery disease. Their stress myocardial blood flow cutoff values for identification of coronary artery stenosis more than 50% at the global and regional levels have a good combination of sensitivity, specificity, positive and negative predictive values. And ultimately, the dynamic CT perfusion may serve as a useful adjunct to coronary angiography to improve the specificity of detection myocardial ischemia. Thank you so much once again for the invitation and for the opportunity to represent the results of our work. And if you have any questions, do not hesitate to contact us. Just you can write our message or just email, text us something, and of course we will be able to respond all the questions during the Congress. Thank you. Have a good day. Bye.